it's kind of primed to then break off and fall into that patient the next time that it's used. And again, like if it's a bacteria that's coming from a biofilm, it is a bacteria that's already primed to begin creating a biofilm on its own. It's like, this is what it knows. This is what it does. And again, it's that when those biofilms form inside of a sterile body cavity, that is the primary cause of antibiotic resistance.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we are speaking with Mike Matthews, a clinical education specialist with HealthMark, a 𝗵𝘂𝗂, and breaking down the first step in the instrument reprocessing lifecycle. We're going to be talking about point-of-use treatment. And it is so important that we understand our role in the process and that we know how we are supposed to properly care for and clean our instruments. And I think Mike is going to really help us see the point, so to speak, of point-of-use treatment. So don't go anywhere. We will be right back with Mike Matthews.
From the studios of Healthcare HQ, you're listening to First Case.
On this week's episode of First Case, we are speaking with Mike Matthews, clinical education specialist with HealthMark, a 𝗵𝘂𝗂. And Mike, you are no stranger to the microphone or to this podcast. You've joined us before and we didn't scare you off. So thank you for joining us again today.
Yeah, my pleasure. I always love getting the opportunity to talk to the First Case audience. This is one of my favorite podcasts to do an appearance on and get to talk to, and I love talking to you. So this will be a good conversation.
No, it's going to be, thanks. It's going to be really good. This season, we are talking all things sterile processing and following the life cycle, so to speak, of instrument reprocessing. And today, we're going to be looking at where reprocessing really begins. And guys, I'm going to give you a hint. It's not in decontam. But before we get into our conversation today, Mike, why don't you go ahead and just introduce yourself to everyone?
For sure. I'm Mike Matthews. I am with HealthMark as a clinical education specialist. My background is in sterile processing. I spent several years as a technician and as a manager before transitioning over to the vendor side, where I worked as an education manager and marketing director for an instrument repair company, and then decided that I wanted a new challenge. And that's when I ended up with HealthMark talking about, surgical consumables.
All right. So last time we had you on the show, we actually talked about bioburden and biofilm and all of those things that our instruments are subjected to, especially when we don't take care of them properly. And so all of you listening, I do encourage you can go back and look that up. You can search Mike Matthews in our podcast list and find that other episode, because I think it actually ties in really nicely with our conversations and themes for this season too. And it actually even fits in well with this conversation today. But like I hinted at a minute ago, sterile processing does not begin in the sterile processing department, does it, Mike?
No, it does not. And I love talking about this topic of point-of-use treatment because it hits so many important themes. And I think the biggest theme that it hits really is about the culture of the operating room. And I don't just mean the procedural room where the surgeries are taking place. I'm talking about the full, encompassing thing, the umbrella of peri-op, because really what we're talking about when we talk about point-of-use treatment is exactly what you said. It's understanding that instruments move in a closed loop. And consequently, and this is why I say it goes back to the culture, is that if you've got a culture of, listen, I just want to make it through the day, push the instruments out of the room, and now it's not my problem anymore, guess what? It's coming back to you.
And it will be your problem very soon.
Absolutely, it will be. Yeah, what goes around comes around in those closed loop systems. And so oftentimes if you're in a department where, the instruments aren't available, the instruments aren't performing the way that they're supposed to, you get biofilm and bioburden, usually your instinct is to go yell at that SPD staff. But the reality you have to ask yourself is, were they set up for success or were they set up for failure?
That is a great point to make. And I think that I am collectively putting all of the OR into this we statement. So if you are not part of this we, then I apologize. But I think a lot of the time as OR staff, we get our instruments and we are quick to point the finger back and say, well, they did this wrong or this wasn't done correctly. And look, where I work, we have a lot of issues, sometimes with our trays not being, correct, or having an issue with an indicator or bioburden or all of these things. And I think that's something that we all experience. But like you said, there's a lot more going on here than just how it got pushed out of sterile processing into our rooms. And we have to take the responsibility for that, because sterile processing isn't in the OR when we're doing cases. Who is? We are. And so when we look at that point of use cleaning, point of use is the operating room, not sterile processing.
Absolutely.
Here we are. Point of use cleaning. What are we actually talking about?
Well, it's kind of a broad term, right? And actually, the Joint Commission, I think, preferred to move to the term point of use treatment because point of use cleaning kind of got convoluted into what is actually meant by that. But really, there's two primary things that need to be considered when we talk about point of use treatment. And one is typically what we think of. It's the spraying of the instruments after the case with something surfactant or something that keeps the bioburden from drying onto the instruments. But really, the definition of point of use treatment is much broader than that. It's not just what happens at the very end of the case. It also includes the things that are going on during the case as well. And so, for example, you just think about that pair of scissors you use at the very beginning of the case, and then you just set it back on the back table, and then it sits there until the case is over. And that might be 30 minutes. That might be 2 or 3 or 4 hours before that's over. Well, that bioburden that was on that pair of scissors that you opened with, well, guess what? It's just been sitting there drying on that instrument for the past 4 hours with no sort of cleaning or treatment applied to it. And it's going to be just as bad as if you just hadn't sprayed it in the first place.
So when we're talking about that type of treatment, when we're keeping our instruments moist on the back table or wiping them down, what is it that we are supposed to use when we are wiping down our instruments, and what should we not use?
Yeah. I love how you're just kind of softballing this one in here, because it is exactly like one of my hobby horses and exactly a thing that, we've talked about several times. But it keeps coming up. And that is that instruments are supposed to be wiped during the case with sterile water. And a lot of times when we tell people that, hey, the instrument's supposed to be kind of wiped, and again, they don't have to be spotlessly clean. I don't think the Joint Commission or anybody's expecting that the scrub techs are, during the case are sitting there just scrubbing an instrument to make sure there's not a single dot of anything on there during the case. That's not what the expectation is. But when we kind of tell people that, listen, the expectation is you're supposed to be wiping the big chunks of stuff off with a fluid, they immediately say, great, I've got tons of saline back here on the back table, right? Because almost every single, in fact, you'd be hard pressed to think about surgical procedures that don't include some form of saline. It's very, very rare. The problem is that what makes stainless steel is this protective layer of chromium oxide that sits on top, and that's what keeps instruments from rusting. But chromium oxide has one weakness, and that weakness is chloride ions. And the most ready source of chloride ions in the OR is saline, NaCl, sodium chloride. That's what is in there. And so you're literally cleaning that instrument with the thing that it is most weak to.
So funny story, I was in a different OR than the one I currently work in. This was a couple of years ago. And I had a particularly snarky CRNA who liked to throw questions at me and just to see if I knew what I was talking about, or just to see if he could prove me wrong.
No way.
I know, right?
That's unbelievable. Yeah.
It was always, and everything was always a challenge. Well, why are you doing it that way? That's not how you're supposed to do it. Those kinds of things. And one day I made a comment about needing to put some sterile water on the back table so they could have it for their instruments. And he's like, we've already got all the saline. What does it matter? It's all fluid. You can just keep it wet with that. And it was always very aggressive in these questions. And so I channeled my inner Mike Matthews, and I, brought up, chloride ions and this and that. And as soon as I started talking about ions and this number, I saw his eyes glaze over, and he just kind of like, okay, we're done, moving on. So I don't think he was prepared for a very chemical answer.
But it's critical. I mean, this is chemistry that we're talking about. And again, since we're talking about point of use treatment, I think it's also important to note that in the OR, saline isn't the only source of chloride ions. It's probably just the most concentrated form of it. But if you look, a lot of your disinfectants like betadine will probably have chloride in there. And of course, blood. Your blood has sodium in it as well, right? And so these kind of sources, they sort of combine to create sort of these worst case scenarios for these instruments. And they will begin to degrade that stainless steel. And again, it's not just like your scissors, but think about like all your complex instrumentation is made of stainless steel as well. It's your ortho drills, it's your rigid endoscope, the sheaths on them as well. And so when those things start to degrade, they become not only uncleanable, but also physically dangerous for patients. Again, probably not in that case, but thinking about the continuum of care, it's not just that case you have to be concerned about. It's the next case and the case next month and the case next year.
You're right. And so when we think about how that chain, how it's all connected, then we have to think about, okay, then why does that correct moisture matter as we are protecting our instruments? What's happening, and what are we preventing, or what are we doing by keeping those instruments moist?
Yeah, I mean, and that really is kind of the main meat of the conversation, right? Is like, what is the purpose of this in the first place? And we kind of alluded to it earlier when we're talking about the cleanability of the instruments, and especially when we get into subjects like biofilms, that when bacteria are in sort of like this, suspended state, they're just kind of free floating. They're not very active, and they're really, really easy to kill. But when they are allowed to adhere onto a surface, and especially when they've got a ready food source at that surface, that's when they start to grow. And when they start to grow is when they start to create biofilms. And when they start to create biofilms are responsible for two things that become critically important, especially when you think about patient care in the operating room. The first thing is biofilms are hydrophobic, meaning they repel water. And guess what sterile processing is going to use at every phase of the cleaning process? Water. It's in the decontam sink, it's in the ultrasonic, it's in the automated washer, and guess what the steam in the autoclave is made out of? It's all water, right? And so if you have bacteria that are protected by this shell of something that repels the thing that we use to clean and sterilize, chances are they're not going to get killed, right? So you have that infection risk to begin with. And we have multiple cases of instances where inadequately cleaned instruments have led to patient infections, right? So I feel like I have to keep saying this because it does keep coming up. There is no such thing as sterile bioburden. It does not exist. And we have many instances where patients have been hurt and killed by bacteria that made it through the cleaning process and then were delivered to sterile tissues, right? So that's number one risk, is that hydrophobic film. But then the other thing to know about that too is that once the infection starts, biofilm forming bacteria are your antibiotic resistant bacteria. And so you think about some of your worst biofilm formers, it's things like Pseudomonas, right? Pseudomonas is a killer. It will kill a patient. In fact, one of the best studies for understanding the value of sterile processing is a 2011 study for arthroscopic shavers that happened at Houston Methodists. And at Houston Methodists, again, you think about arthroscopies, you're an ortho person. Arthroscopy is like one of the safest surgeries that you can possibly have. Like, it's minimally invasive. And the biggest thing is your patients who are having arthroscopies are not sick patients. They're usually active people, athletes, that sort of, they're healthy people with healthy immune systems. And yet in 2011, they had multiple patients get sick, and a couple, they didn't say this in the paper, but it's my understanding that at least one patient died from an infection that was sourced back to arthroscopic shavers, and the bacteria was originated in the sink and decontamination, right? And so the point of this is that yes, bacteria do make it, they can make it from the sink and decontamination through the cleaning process, through the autoclave, into sterile tissue. And then once that infection sets in with certain types of bacteria that are primed to do this in the first place, they are your hardest to treat once they're actually into the patient.
And those biofilms, they're not always, it's not like you're going to look at your instrument and be like, oh, this is crusty here. Let me see this and scratch it off. A lot of times, in my understanding, and please help me understand if I'm wrong, but my understanding is a lot of times you might see those in maybe more hidden places, or maybe in joints, or in places where there would be, it'd be more difficult, I guess, to get in and clean to begin with. And that's
Absolutely.
where that bacteria proliferates. But then also, I like to think of biofilm. I think actually you and I talked about this in our last interview, but talking like a slime house, right? Like there's a
Yes.
slime over that bacteria. But for that to then get into the patient, does it get broken off and then part of it gets into the patient? Is that how it then transfers to the patient?
Correct. Yeah. In fact, it's probably the sterilization process that makes that possible. Oddly enough, yeah, very paradoxically. But usually what happens when the bacteria is exposed to steam, kind of the pressure and force of the steam will cause the top layer of the bacteria to die. And then that's when you see it sort of naturally sort of sloughing off. And then since it's kind of the top part is broken now, but all the rest of the bacteria is still there protected, next time something flows through that cannula, and usually, like you said, a lot of times it's the cannulas, anything that has a lumen, like that's where your primary danger spots are, because that's where bacteria like to grow in, and you can't see it, right? So you can't see it to scrub it or anything like that. And it's kind of primed to then break off and fall into that patient the next time that it's used. And again, like if it's a bacteria that's coming from a biofilm, it is a bacteria that's already primed to begin creating a biofilm on its own. It's like, this is what it knows. This is what it does. And again, it's that when those biofilms form inside of a sterile body cavity, that is the primary cause of antibiotic resistance.
This is just terrifying. It just grosses me out. It's like, ugh. But okay. And see, the thing is like, and I think lumen, and I think like, we push something through and all of a sudden we see all these like chunks of cement come out of something or whatever. And that has happened. And that legitimately happened. And that's bioburden, that's not, or that's, something contamination, whatever. It's not biofilm, because biofilms are those things we just cannot see them. And so to think about
they're
this,
usually clear.
it's just terrifying. So we have bioburden, we have biofilm, we have two of these terrifying things that can later cause harm to a future patient, and our role in preventing them. So looking at that, going back, I guess, to point of use treatment. You talked about removing the gross soil during a case, keeping things moist, spraying our instruments at the end of the case. And then I want to talk a little bit about spraying instruments, just because a lot of times I've seen some OR staff get really salty about being told they have to spray all of their instruments, and then case carts get audited, and then they get told, well, you didn't spray your trays and they need to be sprayed. And so like, okay, fine. So they put all the trays in the case cart and just spray it, all over into the cart. Fine, I sprayed them. They're sprayed. And okay, technically, yeah, there's spray in there, but did you actually do any good? So can we talk about spraying instruments a little bit, and what are we doing?
Yeah, well, so first of all, let me address a myth in the industry, that it has to be an enzymatic spray. It does not have to be an enzymatic spray. A surfactant is fine. So, and again, it kind of goes back to what is your goal? And the goal is to keep the biofilm, keep the blood, which is the container in which the bacteria live, and it's also their food source. Mm-hmm. But if you can keep that from sticking to the surface of the instruments, then it makes it exponentially easier to clean, and it keeps the bacteria from growing exponentially like bacteria like to do. And so what are we doing then when it comes to spraying the instruments? And again, I think you're absolutely right. Like that's typically what we see, is that when somebody sprays it, the word spray is not well defined. And so they're like, squirt, squirt. Okay, I'm done. All right. Yeah, I did it. What else do you want? Right. And the first thing, let me address on that first off, is I get a lot of pushback, particularly from scrub techs when we talk about this. All of the standards, it doesn't matter who you're talking about, AAMI, AST, AORN, anybody who has anything to say in this space. Sometimes they don't agree on stuff, but one area they are remarkably well aligned is point of use treatment. Now, like they all basically say the same thing. And so sometimes I do hear scrub techs who say, well, I've never heard this before. I'm like, bro, you took a test. Like, you're licensed. I know this was on the test. Yeah, like you're licensed, you're certified, depending on what state you're in, but regardless, you took a test, right? And so this is on the test. And so I don't know, maybe if you just failed that section,
or didn't pay attention.
Maybe you did, but whatever. But the point is like your standards, AST says this. And because your OR policies and procedures are based on these standards and guidelines, I'm pretty sure your policies and procedures say exactly this too, right? Yeah. So that kind of feigned ignorance of, well, we didn't know what we were supposed to do like that. I'm sorry, no, that just does not pass muster at all.
Yeah.
So what are they supposed to do? And again, I think this is why point of use treatment is so critically important, just for identifying what's going on with your culture in the OR. And if you really understand the purpose of point of use treatment, you're going to want that surfactant touching all the surfaces of the instrument. And so that means, yes, that means your hinged instruments have to be open. That means instruments that are supposed to be disassembled have to be disassembled, right? And you have to spray it in a way that gets all the surfaces of the instruments covered with this surfactant, because if it's not touching the surface of the instrument, it's not doing anything.
Right, it's not doing its job. Right.
And again, like I think this goes back, like you said, that like I was saying, the culture, because if the entire continuum of the OR's culture is just hurry up, do what's necessary to make it through the day, do what's necessary not to get yelled at, you will see that come out in places. And point of use treatment is one of those places it will come up. It will also come up with those instrument sets that you're opening in the OR too, right? When you find bioburden, when you find instrument sets that are miscounted, when you find instrument sets that are all like, disorganized and things are just kind of strewn in there, it's because they too have adopted this culture of move it through as fast as I can. Once I pull it out, it's not my problem anymore, right? And so it's like you see this on both sides, and that is symptomatic of a culture issue that's happening on both ends.
Right, right. And it's the failure to connect the dots or the links in the chain and realize that I'm creating this problem that's coming back to me that's now delaying my cases because my instruments aren't, or I'm at least playing a part in this problem. Yes. It's not all the OR by any means. It's not all sterile processing either, but the links in the chain break, and then we are all creating our own problems for later.
Correct.
One other thing that I see sometimes too, and some places say to do it, some places don't. And I don't think it's actually in any guidelines as much as it's just a practice that I've seen. But the whole getting a blue towel wet with sterile water and then putting it on the instruments or putting it on the trays, is that an acceptable way to keep your instruments moist as they go to sterile processing?
Yeah, so that actually is in the standards, and it's kind of viewed as like the bare minimum.
Okay.
Because again, you're keeping the humidity level near the instruments high, and that's the purpose of the fluid on that towel. Is it kind of keeps the humidity level high, and it keeps the instruments from drying out. When that blood dries out, that's when the proteins from the blood really start to adhere to the surface of the instrument, and that's when the bacteria start to really go to town in terms of growing and using it as a food source and all that sort of stuff, right? And so that's kind of always been viewed as like the very bare minimum. If you can do nothing else, at least put a towel that's been soaked with sterile water over the instruments to at least keep them moist. And so you can do that, but it's by far not the best thing that you can do. The best thing that you can do is obviously clean it during the procedure. Again, we're not talking about spotless, just the big stuff. And then, of course, using some form of a spray with a surfactant to prevent that from adhering at a molecular level altogether.
Okay, so real quick, because we've said this word a lot, but somebody might not know. What exactly does surfactant mean? What is that?
Yeah, so surfactant is a chemical that releases the surface tension of usually of water, but it can work on other things as well. And so typically when you think of a surfactant, what you're essentially doing is you're preventing something from sticking to something else. And I don't want to get too much into the chemistry of how it actually works, but essentially that's what it does, is it just keeps something from sticking onto something else.
Right. And then our enzymatics, like we've talked about, they have an enzyme in them that then breaks those things down as well to keep them from sticking.
Yeah.
Okay. So as we've talked about the scary side effects of not cleaning our instruments, and it always just makes me want to vomit when I think about it. But the importance of point of use treatment, and I need to make sure I say point of use treatment and not point of use cleaning, because I've been doing this a long time and that's just what we said, but I'm trying to change my vocabulary. But anyway, are there any other mistakes that you see or that you have seen in your time in doing education and in the ORs, or things that we're doing wrong that we could do better?
For sure. And I mean, there are a few, but I think the one, especially somebody coming from a background in instrument damage and instrument repair, the other mistake that I see a lot of times is, again, kind of flowing out of this culture of just hurry up and get it out of the room, is just throwing all your instruments into a pan and walking away. And again, like, I really think that instrument and device transportation is probably the single biggest savings opportunity for preventing damage to instruments, because the way that they're arranged is going to either help prevent damage or it's going to cause damage. And again, like, this is really kind of basic stuff, like the way that we wrap our cords after a laparoscopic case. You know, I see so many times cords come in where they were just kind of like wrapped around the fist, you know, or that, you know, I've been in decontamination, you know, and I pull out a camera and it's like, it's got knots. And it's like, how does that even happen?
Right.
You know, and like, those are the things that lead to damage, again, over the long term. And of course, you're thinking about like, you know, your rigid endoscopes. If you're doing any sort of flexible endoscopy, including like urology in the OR, it's not just in the GI lab, but you know, flexible endoscopes are used there in the OR as well. You know, those are incredibly delicate, and anything that's put on top of them, even if it's something light, will lead to potentially damage. And it's really interesting. There used to be a video on LinkedIn, and I've looked for it several times, but I can't find it. But somebody put like a GoPro inside of a surgical instrument set, and then just pushed that case cart down the hallway. And it's really interesting because you can see that those instruments just vibrate the whole way. Because you think about it, your case cart, it doesn't have shocks on it, right?
There's no suspension there.
Yeah, there's no suspension, right? So like every single little tiny bump gets kind of transmitted through that metal case cart and then distributed onto those instruments. And so your instruments are bouncing around, even if you're not being like crazy or anything, like just the bumps on the floor cause this. And again, that's one thing if you're talking about, you know, stainless steel hemostats or something. But when you're talking about glass and a rigid endoscope, or if you're talking about very delicate, you know,
fragile instruments,
𝗳cie𝗂𝘁 needle holders, and, you know, like just a little bit of bumping into something else can absolutely cause damage. And so it's not just about preventing the blood from drying. That's a huge part of it. But you can also prevent or cause damage just simply by the way you arrange the instruments.
We don't think about it. We don't think about all of the perilous ways in which I guess we abuse our instruments sometimes, and the, you know, damage it can cause. But then damage, if there's scratches and dents and different things in, once again, we have created another place where bacteria can harbor and grow, and or just damaging the instrument in general, which is then a financial cost to the facility.
Well, and again, like going back to the OR's value prop, like, I mean, that's why when you're scrambling around looking for an instrument for your next case and there's nothing available, well, because the other one was broken, right?
Right.
You don't have enough drills to make it through your total joint procedures. Why? Well, because the reamers were broken, and so we had to send them out for repair, right? Like those are the kinds of things that happen because the instruments aren't taken care of. And again, it doesn't show up that one time you ignore this, the one time you're in a hurry. It shows up weeks or even months later, and it's that headache that happens next week or next month. Yeah. And so again, like it's about understanding the full continuum of care and how those instruments move through that continuum.
Mike, our time is up, and I don't like that. That's too fast. This whole season, though, I'm excited to follow this life cycle and look at how our instruments are moving through, because I think as operating room nurses and techs and anybody else within the perioperative space, like, we need to understand the role that we play in it and realize that it's not just an isolated job that sterile processing is doing, but we play a part in it. And so it's great to have these conversations. But before we wrap this up, do you have any other final thoughts, any other advice, or anything else you want to leave our audience with?
Well, you mentioned one thing, and I was going to bring it up, and I'm really glad to hear that your facility is doing this. I think one of the best things that you can do is do decontamination audits.
Yeah.
And a lot of places aren't doing that. That's why I was really glad to hear that your location is. It's still a very rare practice. But it's a great practice to kind of, again, hold the OR accountable for what the expectations are, whether that be just the arrangement or the spraying or all of the above, and communicate that back. And again, like if I'm a sterile processing technician and I give you an instrument set that has bioburden in it, or if I give you an instrument set that is badly arranged or badly counted and it affects your case, chances are I'm going to hear back on that. And I should. It should. Like that's your responsibility as a nurse to hold somebody accountable for putting, instruments in their hands that made the case more difficult. Like, it's a good thing for the SPD to be held accountable in that respect. But we also need to hold the OR accountable. And I think the best way to do that is by auditing the condition of the instruments as they're coming down, and then reporting that back to the OR and holding people accountable on that end as well. So everywhere there's a transition point, there should be some sort of monitoring, auditing, and of course, accountability.
I think that is excellent advice. And I think we can call it the mutual responsibility that we have for ensuring patient safety, making sure that we provide great patient care, and that we're, being responsible with the instrumentation and instruments that we have to. So, Mike, thank you so much for joining us. This has been an excellent conversation.
Yeah, my pleasure. It's always a great conversation when we get together.
Yeah, I enjoyed it. Thank you. That was Mike Matthews, a clinical education specialist with HealthMark, a 𝗳cie company. And I think that our conversation today was so important because it is crucial that we remember our role in the sterile processing process. We play a part in ensuring instrument cleanliness and safety, and in ensuring patient safety with the instruments that we use. It's really easy to complain when we get instruments with bioburden, but are we paying attention to our instruments during our cases? Are we cleaning them as we go? And are we spraying them when we're done? Are we doing all of the things that we should be doing to make sure that sterile processing gets the instruments in a manner that then they can thoroughly clean and reprocess and get back to us? We have a part to play. We play a very important role in the process, and it's important that we understand that. But that is going to do it for this week's episode. Stay tuned next week as we continue our walk through the instrument reprocessing lifecycle and head into decontam. So on behalf of Chris, myself, and our whole team, thanks for listening to this week's episode of First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.